Well, once again, good morning, everyone. It has been my pleasure to be your morning host this week. Monday through Friday, of course, we are having our annual CSI virtual symposium. Welcome to those of you who are joining us for the first day. No worries, we are recording this, and so I know there are going to be the other sessions that you may want to go back and listen to once we conclude the week. We will be putting out the recording and the slides for those sessions that those are appropriate for on our website. I am Marisette Hassan with the Coalition for the Care for the Seriously Ill. And as I've told you, that is a mouthful. So we call ourselves CSI. We have been in existence since 2010. In the early years of our coalition, we really have just sort of put a stake in the ground around POST, the physician orders for scope of treatment, and did a pilot through the leadership of our post work group and Wilma Rice during the years of 2014 to 2017 in a partnership with the Department of Health and Environmental Control. We've also had the privilege of doing some grassroots campaigns around advanced care planning in our underserved groups in South Carolina with a large grant from the Blue Cross Blue Shield South Carolina Foundation, and which we'll tell you a little bit about that later on. So this week has been absolutely amazing. Kicking off on Monday, looking at the veterans and their eligibility for hospice benefits and concurrent care. Alexis from the Ralph H. Johnson Veterans Administration shared with us some amazing, informative pieces of information, and most importantly, she gave us contact names for people that we can call in the regions in North Carolina and South Carolina. You absolutely want to make sure you get those slides. And then on Tuesday, we talked about compassion fatigue. How do we prevent burnout with Morgan, really giving us a sense of how we need to fill our own cups so that we can pour into others. And then, of course, on yesterday, Tracy gave us, Dr. Tracy Fasolino, a deep dive on all of the hot topics that are happening legislatively and advocacy-wise in Washington, as well as what is going on in South Carolina. And man, that was an exciting discussion. Now, Tracy did say to us on yesterday that most people do not think that legislation and advocacy is a sexy topic. But Karen, you and Autumn and I know that, hey, we can get a lot done. And there are some things that we're going to hear about today that's been happening. It's my pleasure this morning to introduce to you two amazing ladies from North Carolina, part of our North Carolina Serious Illness Coalition. We call them our sister coalition because we have the same host and backbone. That is the Health Sciences Health Innovation Group. And so Karen, who helps to lead the engagement and caregiver work group there for the North Carolina Serious Illness Coalition. And then she's brought along with her also Autumn today. So we have the dynamic duo. And I want to share with you just a little bit about what Autumn has been up to, as today we're going to be really talking about the caregiver connection piece as it relates to serious illness care delivery. Autumn Campbell is a director of the Partnership to Align Social Care and principal at Due West Strategies. At the partnership, Autumn leads the collaborative's efforts to align leaders from community-based organizations, health plans and systems, national associations and advocacy organizations, philanthropic organizations, foundations, academic institutions, federal agencies. You know what? I actually need you, Autumn, to come help me at home. I think you could probably do that too if you're helping all these other folks too. And then also, she is working with some of the networks related to some of the CBOs, the community-based organizations, around what social care looks like. And she has a broad portfolio of experiences in policy and advocacy. We now are absolutely in love with policy and advocacy at the coalition. And she's worked both for Congress as a reporter on Capitol Hill publication of the Roll Call, and where she also has gained some extensive understanding of the federal legislative process. I know for us, when we think about the legislative process, our eyes glaze over. But Autumn understands how that process works. And she and Karen are going to talk to us about one of the newest things that's happened, our ability to support our caregivers. So, Karen and Autumn, thank you for joining us this morning. And I'm going to turn it over to you.
Thank you, Marissette. I really appreciate the introduction. And I'm not going to say a lot other than to just set the tone for how this conversation really got started. And that is that as the Caregiver and Patient Engagement Work Group of the North Carolina Serious Illness Coalition started talking about what we could do around advocacy and outreach, we actually, with the North Carolina Coalition on Aging and the Children's Complex Care Coalition of North Carolina, started another group called the North Carolina Caregiving Collaborative. And through that group, we started putting at the top of the agenda how, we looked at a lot of the areas that dealt with caregiving as a topic. And we, especially within our three groups, and we said, what if we had a group that really focused on caregiving as the top priority across the lifespan, which members of our group are caregiving and or working for organizations that help caregivers across the lifespan. So we've got people caring for young children all the way up to older adults. And so as we started hearing the commonalities of support needed across the lifespan, this caregiving collaborative really took off. As that group took off, some really exciting things happened. The National Strategy to Support Family Caregivers came out in 2022. And then last year, we found out about these new Medicare billing codes that had some sections of them that were specifically around caregiver training and education. And many of us don't work in the healthcare field or really have a lot of experience in that. So we've been looking to our healthcare colleagues to better understand how a group like ours might be able to do outreach and education to providers on these codes, and also possibly look at what we could do as a group with some caregivers as part of our group with lived experience to actually help figure out if there are ways we could inform training for caregivers when physicians actually start engaging with these codes. So with that, I'm going to ask Autumn to go ahead and get her slides ready, and I'm going to let her take it away. She's got a lot of the background on where these codes, how these codes came about. And she also worked on the National Alliance for Caregiving's policy brief on these Medicare billing codes and how they would advance supports for family caregivers. So that's how we connected with her, and we're very appreciative that she's here. So Autumn, whenever you're ready.
Great, thank you. Well, thank you all for having me today. I'm happy to join the South Carolina and North Carolina CSI team. And just as a little bit of context, so I do work with the National Alliance for Caregiving, and the introduction was through the National Alliance for Caregiving. I am, however, I come by this work honestly. My career in health and aging, primarily aging and disability services. Honestly, I was a longtime caregiver for my mom for a number of years, a primary care. I have actually lived many of these experiences. Have rigmarole of paperwork and so forth, and the heartache of trying to arrange needed services. So I fully understand the importance for the things that we are talking about today, and I'm sure many of the things that you all have talked about throughout the week here.
Hey,
so
Autumn,
all of that.
Before you get started, is anyone else having trouble hearing her? I feel like your audio is going in and out, and I just wanted to make sure it wasn't just mine.
Coming across a little choppy on my
Yeah,
end.
it's a little bit jumpy. Just
I just wanted to make sure. I thought if we could get that resolved before, if I didn't know if it's on your end, if you wanted to try turning off your camera.
Yeah, I'm happy to. Yes, I'm happy to. And see, is that any better?
Right now, it sounds clear.
Okay, apologies about that. I actually came into the office this morning thinking that the internet connection would be better here than it was at home. So, let me know if it doesn't work, and I will just pause and try to connect to the internet in a different way.
Yeah, now it's breaking up again. So I don't
Okay.
know, Autumn.
All right, let
Yes.
me I'm gonna stop screen sharing and I'm going to connect to the internet here in a on a different connection here. So
Okay.
um
We can
my
chat while you're doing that.
yeah, my apologies all.
No, that's okay. I figured before you got started, if we could resolve
Yeah.
that, then we'll have a good
You know,
presentation.
the Zoom gremlin.
Yeah.
Right. Karen, I really love what Autumn shared in terms of her background as a caregiver. And I seem to recall that you also have had that experience as well. And I think many of us have done that as well. And I didn't know if you minded while she's doing that, just sharing your experience and how you came to really be an advocate as a caregiver.
Sure. Thank you. I really appreciate the opportunity whenever I can to talk about that. I was a caregiver for my mom for 25 years. She had MS and dementia. So I became a caregiver at 31 and had a 3-month-old child. So I was doing the serious sandwich caregiving. But what I learned over that time, and actually this was, you know, my background is marketing, so I had no knowledge of anything to do with caregiving at that time. I just jumped into it, and I learned a lot about the way the healthcare system works. She was walking with a walker in her 50s, so we were dealing with disability. So as I got into it more and started learning about caregiving, and learning all the all the organizations that were working around caregiving and how much work was going on behind the scenes that I never knew about, that I decided that I was going to switch careers. I went back to school, got a master's in gerontology, and never looked back. And actually, have been really I've been touched over the last year. My mom passed away a little over a year ago. And over the last year, I've felt her presence a lot as I've done more advocacy around caregiving. And I feel like it's my way of honoring her memory. And so I'm always thrilled to be able to do presentations like this and be able to work more in the advocacy space to carry on all the work we started on, you know, with the North Carolina Caregiving Collaborative and the Serious Illness Coalition Caregiver and Patient Engagement Work Group. As you said, so many of the people that we're working with are caregivers or have been caregivers. And so I feel like when you're a caregiver, the most advocacy you can do is around your loved one. That's about all you have the energy and time for. And so I feel like I can pay it forward now for those who are in the middle of it to say, we've got this on the big picture end, you know, we'll carry it from here and we'll work on what we can at the federal and state levels to try to get better policies and better supports to help caregivers.
Oh man, Karen, thank you. These experiences and stories are so rich. It is a part of what we have to always bring forward because caregivers need to know they're not alone in the battle. And so when we share our stories, our frustrations, and I personally myself helped to care for my mom some 30 years ago when she had cancer. And I tell people today, and even as a hospice nurse and a senior leader in this field, I tell folks you cannot let your loved ones go anywhere by themselves. You must go with them as a caregiver. And recently, when my husband was so ill 3 years ago with COVID, I was reminded again how much people don't realize. And I had information where I could advocate for him. But so many caregivers are not armed with the information that they have the power to make the choices, to ask the questions that they need to ask of their providers, to be linked in. They just don't know the resources that are there. So I'm so glad that there is going to be this type of work that's going on. So thank you both, Karen and Autumn, for sharing, your personal experiences as well. And Autumn, we're going to turn it back to you.
Okay, great. Is this any better? Great. I came into the office thinking it would be more reliable than at home. So, all right. Let me then go ahead and get started. Thank you all for your patience while dealing with the Zoom gremlins this morning. So I'm going to provide today for you all an overview, and I say overview very intentionally, of the Medicare codes, the new Medicare codes to support training for family caregivers. And the reason I say overview is A, because I am not a billing and coding expert. My work has largely been at the federal policy level. I will not be able to confidently or in depth answer implementation questions, but I'm happy to refer and connect folks to those who might be able to if there is interest in learning more. And then also as Marissa mentioned, I'm the director of the Partnership to Align Social Care. And the partnership has been really involved in developing and disseminating resources implementation around some of the other health-related social needs codes that are included in the fee-for-service, the physician's fee schedule. So we haven't as much caregiver training services codes, and you'll hear in a minute why that is, just to give you that little bit of context before I get started. Okay, so I think it's important to do a little bit of context setting here, and hopefully this is not news to anyone here on this call, but more broadly, the healthcare system is increasingly reflecting the goal toward moving from a fee-for-service payment system to a value-based payment system, right? Paying for value, paying for impacts. And as this is happening, providers are increasingly and strategies that can help address many of the underlying drivers of these costs, such as unmet health-related social needs and more broadly, social determinants of health. There's been a lot of research and evidence over the last probably decade and a half that demonstrates, and I think is well accepted now, that the primary driver of cost, healthcare costs, a lot of times is related to the broader social determinants of health, in which someone has access and their individual health-related social needs, whether or not they're met. Overall, successful implementation of these broader interventions to address, I'm going to say HRSNs, for a particular population requires that healthcare and social care are aligned. And of course, caregivers are a huge component of that, right? Now, what we've seen out of the administration over the course of the last few years is a number of initiatives and efforts, statements, broader executive priorities that are both attributing the importance of health-related social needs and addressing social determinants of health, as well as the administration has been pretty committed to advancing general support for family caregivers. So I think it's important to note that what I'm going to talk about today is kind of one step in a broader process that is moving toward supporting alignment between healthcare and social care, and of course, family caregivers play a vital role in that broader alignment. So again, as some context setting, what's important about what we're talking about today, and why is the Medicare physician fee schedule important in this kind of overall trajectory toward improving alignment between health and social care and improving supports for caregivers. Overall, the Medicare physician fee schedule, it determines how much healthcare providers are reimbursed for services rendered to Medicare beneficiaries. The physician fee schedule first came out in 1991, and annually the schedule has provided policies and reimbursement requirements for physician services at a really high level. I mean, this is a 1,500-page document on an annual basis, and talk about today is pretty monumental, but ultimately relatively small in comparison to the physician's fee schedule. But the important part of that is that, well, the Medicare physician fee schedule sets these rates for services under Medicare fee for service, or traditional Medicare, so Part B. The rates that are set are then applicable across payer models and types. Additionally, Medicare Advantage, Medicare Part C, who many of you may be very familiar with, and arguably, depending on the region of the country that you're in, but often Medicare Advantage is more popular than fee-for-service Medicare. But Medicare Advantage by law has to provide access to the same benefits that are allowed under Medicare fee-for-service or Medicare Part B. In November of 2023, the 2024 calendar year physician fee schedule was published as a draft. It was finalized. The draft was published in July. All of that to say that the 6-month process between July of 2023 and January of 2024 was pretty game-changing in terms of allowing for services to address health-related social needs and to support caregivers to be reimbursed by providers and hopefully through additional payment mechanisms as well. So again, essentially this sets the standard for medical billing and coding broadly, and the implications are pretty wide-ranging. Now, all of that to say that implementation is the key here, and I'll get into that in a little bit. So in the calendar year 2024 physician fee schedule, that final rule, which went into effect in January 2024, January 1, made a number of changes, including advancing Medicare's overall value-based care strategy, making payment to practitioners that train caregivers to support certain diseases or illnesses, and also addressing health-related social needs through services such as community health integration, principal illness navigation. I'll get into some of those a little bit later. I'll touch on them and kind of demonstrate why they're important in relation to caregiver training services. So under the calendar year physician fee schedule, CMS adopted this new set of what are called HCPCS codes. I'm sure no strangers here on this, HCPCS codes or CPT codes. These are the collection of standardized billing codes that represent medical procedures and so forth. These codes caregiver training services, but again, also a number of other codes that were aimed at addressing health equity and supporting caregivers. Another important note here is that while we're focusing on caregiver training services today, caregiver training services, as proposed in the physician fee schedule, and used in conjunction with some of these other codes to address health-related social needs. Okay, so the top lines for the caregiver training services here, and I really want these slides to be used as a resource for folks. So I will try. I'll try to go into depth where so make sure that I am hopefully not putting folks back to sleep on this. So overall, the CTF codes are a new Medicare Part B benefit that are intended to reimburse eligible providers for providing caregiver training services. A caregiver is broadly defined under the new codes as a family member or other person with a significant relationship with the patient and who is unpaid. This definition aligns with some other national initiatives, including the Raised Family Caregivers Act, as well as the National Strategy to Support Caregivers. That alignment was specifically called out and was important in the final physician fee schedule. Now, the CTS codes didn't come out of nowhere. They are a result of several years of advocacy for inclusion, including a proposal in 2023 requesting response about how would there be support for supporting caregiver training services. That's largely positive. I will say the occupational therapists and physical therapists have been, I think, largely the driver behind implementing these codes, and you'll see that here in just a second. But they have, of course, much broader implications. Again, definition of family caregiver, multiple sessions and multiple caregivers can be covered under the CTS codes. There is a recognition that that an individual patient may be cared for by a number of caregivers. So that allowance was made in the final rule. These codes are, and I think this is really important, these codes are intended to supplement and not supplant other caregiver support services and other Medicare services that are available. So, there is no expectation that these codes will cover the gambit of caregiver support that's necessary. They are acknowledged as non-duplicative, and they are not intended, again, to be used in lieu of other federally available supports. The services do require patient or representative consent that's documented in the medical record. These cannot be delivered under general consent for treatment. And the reason that these services require that patient representative consent is because the services themselves are intended to be delivered without the patient present. So again, I think that's an important note, and it's also a bit of a difference in the caregiver training services and some of the other services intended to address health-related social needs. The services must be provided in a setting with the provider present. They cannot be provided telehealth. Again, I think that's an important note and potentially an area for advocacy in the future. There is a deductible and or co-insurance that applies to the services at the time that the patient receives those services. They are not eligible to be waived. For every service received, the patient pay 20% of the cost. Now, again, that's why that consent is required, because there will be that copay. Now, that said, according to Kaiser Family Foundation, up to 95% of fee-for-service Medicare beneficiaries have a secondary policy. So, the broader implications of that copay, while they're concerning, it largely would be covered by the secondary policy. And I think that nuance is important because likely the population that will be most in need of these services, or the population that's most likely to have poor outcomes and high social needs, are the population of dual eligibles, and by definition, Medicaid is that secondary policy for dual eligibles, so there wouldn't be an out-of-pocket expense for the caregiver training services. Okay, I'm gonna pause before I move on. I just want to make sure that I'm not losing people. So if there's any requests for clarification, feel free to. Okay, great. And I realize I may be speaking to experts in this, so appreciate you bearing with me. I think the context setting is important. So the caregiver training services are also different in the other health-related social needs codes that were included in the physician fee schedule in that the CTS services are limited in terms of the providers who can provide those services. So the CTS eligible providers include physicians and non-physician practitioners and therapists. This includes nurse practitioners, physician's assistants, family health, family therapists, mental health counselors, and then of course, physical therapists, occupational therapists, and speech and language pathologists. Noting that many of the non-physician practitioners and therapists have a training basis, an education basis in caregiver support and training. That's less common, I think, than physicians, and some of that will come into play when I go over some of the rates and so forth here. But the intent of these codes largely is that they would that they would be billed through a non-physician practitioner and therapist, but also eligible. Okay. Again, kind of high level here, the overall billing, time-based billing, and these codes can again be billed in conjunction with other health-related social needs codes. It's important to note that the caregiver training services are available in individual and in group settings. So that again, that's another difference between these and some of the other health-related codes that are only eligible for individuals. So the billing itself is based on the number of patients being represented, not the number of care being trained. So this is kind of where that allowance for multiple caregivers for one patient comes into play. The provider will not be able to bill for each of those caregivers. The provider would only be able to bill for the patients that are receiving on behalf of which the caregivers are receiving training. There are a couple of different categories for the caregiver training services. The two categories are behavior management and modification training. So that's training patients or for caregivers of patients with mental or physical health diagnoses. And then there's a training to facilitate functional performance. And these are primarily regarding activities of daily living, instrumental activities of daily living, such as mobility, communication, swallowing. You can see some of the examples here. So essentially two different categories of caregiver training services. And I won't go into this slide here in depth, but for reference purposes, it may be helpful to have the broader codes. The behavior management and modification training can only be provided as a group. So there's no individual behavior management or modification training code. Then the other codes here include both the initial billing code for the individual and group training for functional performance, and for the group training for behavior management and modification, as well as the add-on codes for additional time provided. Again, a key component of these codes is that they are not intended, these services, is that they are not intended to be delivered with the patient present. So the patient is not going to be present during the caregiver training services implementation. Okay, I wanted you to do just a little bit of an overview in terms of how the caregiver training services fit in with some of the other, again, really kind of milestone or monumental codes that were included in the physician fee schedule intended to support health-related social needs. So additional codes that were include social determinants of health screening. And this is administration of a standardized evidence-based SDOH risk assessment. This is not intended to be delivered more than every 6 months. And services are rendered during an evaluation and management visit. Based on the risk assessment, then the patient may be eligible for Community Health Code, CHI, or Principal Illness Navigation, PIN, or Principal Illness Navigation peer support code. And essentially, community health integration services are intended to address unmet social determinants of health needs or health-related social needs that affects the diagnosis and treatment of the patient's medical problems. So specifically, if just as an example, if a patient has limited access or unreliable access to housing services, and because of that, they can't keep insulin cold, and therefore their diabetes is going untreated, that then the need to connect someone with housing services could be considered that CHI code, under that CHI code. So the principal illness navigation, they are intended to help people with Medicare who are diagnosed with high-risk conditions, for example, dementia, AIDS, cancer, identify and connect with appropriate clinical and support resources. So those two are a little bit different, but for purposes of today, the reason that I am referring to those is that, again, the broader context of this is that these codes can weave together a story, right, to fit the needs of an individual patient. So this is just one example, and I failed to mention this at the beginning, but I want to be very clear. The information I'm bringing to you here today is certainly iterative of other information that that groups have been working on, including the Partnership on Social Care, but also Friedman's Health Consulting has done quite a bit of work on developing implementation models for some of these opportunities. So I want to make that very clear, that again, the codes are not, the CTS codes specifically are not intended to be delivered in a vacuum. So example, to the hospital, they're trying to find resources, the hospital's trying to find resources for them that links back to potential billing opportunities. These billing opportunities may include, just as an example here, transitional care management, advanced care planning, which I think we may talk about here, detailed assessment, then caregiver training on an individual basis, and additional health-related social needs activity to address some of those individual health-related social needs. One more note, and this is just, I think, indicative of kind of how these things are connected more broadly. But caregiver training is also eligible service under the principal navigation codes. So the PIN codes can be used to kind of reinforce whatever caregiver training was delivered in a clinical setting. I think that's, again, an important nuance. Okay, so there's a few things here that we want to be aware of around the caregiver training services. Again, this is not a fix-all. This is not an easy button. And there are future opportunities for advocacy that I think some of the implementation experiences and challenges can inform moving forward. The physician fee schedule is an annual effort. So if, for example, if in 2025, advocates identified that caregiver training services should be eligible to be billed by providers other than physicians or non-physician practitioners and therapists. So for example, by auxiliary providers, that could be an area of advocacy for 2025. That was certainly something that we had advocated for in 2024, but this is it's a step-by-step process, incremental radicalization or something like that. The overall, I think, general concerns around the caregiver training services are that, number one, physicians and non-physician practitioners may not have the workforce necessary or the trained workforce necessary to deliver these services. Also, a lot of caregiver training supports generally are delivered through community-based organizations, right? So there seems to be a natural alignment there that you would want to encourage the collaboration with community-based organizations to really make these these codes to realize their potential. I think the rates as well are somewhat concerningly low. So that's something to be aware of moving forward and to potentially advocate for in 2025. The practicality, and I think Marisette spoke to this a few minutes ago, the practicality of a physician's office who is overwhelmed anyway and has a lot of hoops to jump through. To implement something new is challenging, right? So this is going to take a lot of education. This is not, as with any new code opportunities or billing opportunities included in the physician fee schedule, this is not something that just because you can do it means you will. And again, physicians, while they're eligible providers, aren't necessarily trained in delivering caregiver support services. So they would need to be working with another provider who is trained. So let's see, in terms of next steps, I think it's important, and this is again just mainly for resources here. There are some resources that are available, reliable resource, objective resources, I should say, reliable for learning more about this. I've included a few links in my slide deck here. Specifically, CMS recently released an FAQ document around the broader health-related social needs codes that were included in the physician fee schedule. So that may be something to check out. The American Physical Therapists Association has guidance on the use of these caregiver training codes, but it does require membership to APTA. And like I said, the Partnership to Align Social Care has been pulling together implementation resources for other health-related social needs codes that are applicable to caregiver support. So that might be something to check out. One of the things we talked about before I spoke here today is, can we find some implementation examples? Like, are there organizations that are doing this already? And as of a few weeks ago, I knew of 2 implementation examples. I don't know details, other than to say that Corewell Health in Michigan is working with the local area agency on aging. And the area agency on aging is actually providing, they have therapists and so forth on staff, and they're providing those providers to Corewell Health to deliver some of these caregiver training services. Zercoa in Alabama is another area agency on aging that is similarly working with providers by providing therapists that they have on staff to provide groups specifically around caregiver training services. I'm sure there will be more examples, as we move forward here, but they were pretty limited. Okay, great. Yeah, we're still in the discovery process here in terms of, figuring out how this is all going to come together. And before I conclude here or turn it over to conversation, I just want to note that, again, these services are not going to supplant other available caregiver support services, which arguably are too limited. There's not enough federal or state support for caregivers. So I would encourage everyone here in your advocacy to make sure that you, well, it's an important milestone, an important step forward, that you are still prioritizing many of these other programs, as well as that you know about these other programs for yourself or other caregivers that you may be interacting with here. So I wanted to make sure to at least include a few resources there that were outside of the specific caregiver training services featured in the physician fee schedule. So I'm happy to conclude there, but I will turn it back to the CSI team to
Wow. I'm sorry. I was so busy writing and typing. Wow. The thing that gets me about a presentation like this is it's informative, but it also spurs thoughts about action. And a couple of things you said, I wanted to bring it up, and I may put it in the chat so it's in there. I loved your comment where you said codes can weave together a story to fit the needs of an individual patient. And I just thought that was a great way to really go back to that whole lived experience thing, where those of us who have done it or are doing it, when we're looking at the whole patient, often you go into a physician's office and they're looking at one specific thing, and that whatever their specialty is. And so I love the idea of, you get this knowledge that there are these other codes, and that when you look at physicians' offices as businesses, they have to make sure it makes business sense for them. And so I think one of my big things would be, I think you just spurred us on to that we've got some work ahead of us to really, as a group, start putting together some thoughts on outreach and education on the physician side, on the provider side. But where to even begin is sort of a little bit overwhelming right now. I also loved your comment, incremental radicalization. I love that. And I think that your comments about advocacy opportunities, again, I think those are things that we can be thinking of as a couple different groups on how we might want to move forward on initiatives that we're working on. So I think I'd like to open it up to, well, maybe we don't open it up to questions yet, because I do think if Marcette would be willing, maybe we talk a little bit about your experiences with previous Medicare billing codes, if you don't mind, and then maybe we can open it up to the group just to talk a little bit more about questions that people might have as people digest the information that Autumn just went through. I think it was wonderful. It was a lot of information, but really well informed, and we really appreciate you being with us, Autumn. So Marcette, you and I started talking a while ago, and the
So
thing
Karen, before you move on, Jessica, I think, has a burning question, and she was
oh,
the only person who I saw whose hand was up. So I would
yes.
love to allow Jessica to go first, and then we can continue our discussion. So she can connect it to what we just talked about. Go for it, Jessica.
Oh, thank you so much. So first off, Autumn, wonderful presentation. So I actually manage a team of behavioral health care managers. So we do collaborative care and care management. So we work under the supervision of our providers, like our primary care providers. These codes, are they part of an incident to billing, like, because they're not, we don't have them kind of paneled, or do they have to be kind of independently paneled providers to be able to bill this service?
Yeah, so that was a significant area of advocacy, and I think candidly, in the final fee schedule that came out, and probably one of the reasons why, Jessica, you're not seeing more activity around providing guidance and support for implementation. They're not incident to. The other health-related social needs codes, community health integration, principal illness navigation, peer support, they are all the two. Also under principal illness navigation, billing opportunities, caregiver support services are an allowable service. Whether that can be done in absence of a CTS caregiver training service initially, I'm not sure. I would have to find out. But yeah, they at this point they're not incident to, and that is a very prime opportunity for advocacy in the calendar year 2025 physician fee schedule.
Thank you so much.
Can you,
Absolutely.
for those of us who don't know what that means, can you explain what that is? Incident to?
Yeah, I can. I actually might put Jessica back on the spot, because I think it might be more helpful coming from someone who actually, who works in that framework. Like I said, I am on a national level, so I know what it means from a policy standpoint. But Jessica, do you want to some clarity there?
Sure. Hopefully I can. So just for a good example, we do collaborative care. So we have licensed professionals, but they're behavioral health care managers, and they are working directly underneath our physicians, APPs, and PAs doing brief therapeutic interventions. And so they're incident to, which means that we bill it incident to the physician because they've ordered it and they are still overseeing the care of the patient. We are just kind of an adjunct service, but we're not taking complete care and treatment. So there's lots of things that we do and work together with our primary care physicians to be able to support their mental health in their medical home.
Exactly. Yeah. The incident two is essentially a broad Medicare. It's a billing strategy or mechanism that allows providers to recommend or furnish a service for a patient. And actually, it would be an auxiliary personnel who is then supplying that.
So actually, before we do go on, maybe we should open it up if anyone else has any questions, because I don't want to lose the opportunity to have people here in case anyone needs to jump off, to be able to ask Autumn any questions or comments on anything that Autumn presented on. I want to open it up to the audience.
And like I said, if I don't know the answer, I'm happy to either
And while people think about that, I think some of the things that that also intrigued me, even in reading about this and then hearing it again, it gets me when I think about how your comments about the community-based organizations and physicians' offices. I mean, we all know that those, like you said, services for caregivers, any sort of training is often delivered at the community-based level. And yet when you're in a physician's office, when you're dealing with someone, especially someone with a serious illness, you want to know at that time how to connect with those. And they often don't have that information. And so I'm intrigued again, thinking about how that connection, we've been talking about that for a long time. How does that connection get made? And this may be our opportunity to really say, okay, now you have an opportunity to bill for you can be compensated for actually working on that. And I'd love to say that some of our groups could get together and help make that happen. Our goal is when a caregiver is in an office and is feeling alone and scared because they're not often medical professionals. And even if they are, I think when you're dealing with a loved one, it's a different story. But then to have to think about, to your point about many of them not having the staff to actually be able to take that on, I think that's a huge thing. So what can we as groups, as organizations that might be on the caregiving side of things say, what can we do to help facilitate that process so that when someone's in an office, they feel like they're not only are they not alone, but they're not being shot out into the world having to deal with all this on their own, that there are supports out there that can help them. And the other thing I go back to is talking about IADLs and ADLs. I remember early on when I first started learning about those, because you don't know about those when if you're not in the medical or gerontological field, you really don't, or others that learn about those, you don't really know what those are. But when you find out what they are, you realize you've been doing them for a long time. So I think every physician's office should offer the checklists that those, when they do assessments and they have those checklists, offer those to a caregiver to say, these are things you can be thinking about as you're going through your caregiving journey. And as you get through the IADLs and closer to the ADLs that you're doing more support with, those are the times that you might want to consider calling in for help, and needing a little bit more support. But anyway, I still want to open it up. I'm not seeing anyone
Yeah,
either.
so there is a question, Karen, regarding distinguishing about the kind of training. The question is related to the tangible education like wound care, incontinence care. And I did think I saw, Autumn, in the slides that when you're looking at physical diagnosis training, that's a particular category. And then sort of the behavioral piece that could be something that would work in that regard. So I'm trying to see the person who put the question. Let me go up and let's see. Was it you, Heather?
Yeah, it was me. I'm just thinking about in my caregiver hat, all the things that would have been helpful and wasn't provided or was sort of provided after I asked and asked and asked. So that's why I was wondering the range, because yeah.
Yeah, so I think that, those are things that can be provided based on the information that's out there. That would absolutely fall in that whole piece of caregiver training, where you could have a couple of caregivers who come in related to patients, and you're training them on these specific tasks. Now, to Autumn's point, this is also where that assessment in terms of, is this caregiver physically able to provide this service in the home? So now that's going to lead me to thinking about, because I got my nurse hat on now, how do I make a referral for some home-based services based on what I found out about my caregiver in that training situation? That they also have had some knee surgery, and so they're not really in the best of shape to be able to provide the care. Or they are going to need some more intensive at-home support in terms of how to check their blood sugars, how to give the insulin, what are some of the things that they need to do in terms of nutrition. Those are how all of these things, as Karen, you said, paint the picture. Not only do we want to tell the patient how to take the meds, but we also want to tell them what they need to do in terms of behavior modification. And the caregiver is the one that's going to the grocery store to buy these groceries for this person who's newly diagnosed as a diabetic, a type 2 diabetic. And of course, we know that there are food deserts. So where does the patient live? What's their zip code? What are the other resources that are available in that particular community where this person can have access to good vegetables? Is there a farmer's market? Is there a church that actually has a farmer's market day that's in that particular rural community? You see where I'm going with this, that whole piece of a social determinants of health assessment also connects with what you're doing physically, because that's going to also impact the person's health. So those are the pieces that are so important. And to Autumn's point, and what I have seen in working with physician offices, they do not have the personnel to do this deep dive. They don't hire social workers, right? They have medical assistants. And so this is where diversifying the workforce talents comes in as well. So when we advocate, we need to go back to Washington, Autumn, and say, listen, let's really take a look at what's going on in our primary care practitioner offices, our specialty care offices. Is there a way that we could provide some training, cross-training, some sort of certification where some of their staff could help with some of this? Now, the doctor's office that I go to in Columbia, South Carolina, is Wellspring Family Medicine. They have one nurse practitioner and they have one primary physician. But what Dr. Daniels has done is sort of diversified what he does for his patients. So he has the ability in that office to do some diagnostic testing. He does some heart-wise stuff related to people with health and weight management. And he now has navigator services where he's partnered with a community-based organization who has put the navigator in their office. So this is that piece of, because there's such a busy office, but the individuals in there need that additional training. Now, one of the things that we were able to do through the South Carolina Coalition is that we had a large grant to be able to do advanced care planning and raise awareness in 5 underserved communities in South Carolina. And what we did with that particular grant was, number one, put up a website that was a consumer-facing website on ACP resources, caregiver supports, clinician training, etc. And then we had trainers that we trained clinicians across the state who now can either train other trainers, or they're able to go into communities through community partnerships and provide workshops on advanced care planning. Well, towards the end of our grant, this was a $1.8 million grant, we also stood up an e-registry, and we had some funds that we could use. We said, hey, we need to look at the physician practices. How are they doing with advanced care planning with Medicare patients who actually can get that advanced care planning without a copay during their annual wellness visit? So we took 2 particular groups, small grants for these 2 groups. And what we found was that, number one, physician offices do not have a process for putting in this additional work. So Dr. Daniel said to me, Marcette, I absolutely want to do more around advanced care planning with my patients, but I just don't know how we're going to fit it in. So one of the things we did was a care mapping of what happens to the patient when they come in, who touches the patient, what questions are asked, and then how does that go in with what the physician is doing. As it relates to caregiver training, one of the things that has to happen is, of course, you got to have great physician education. You know, they need that FAQ. They need to understand how to operationalize that through their practice. Now, those savvy practices have got a business component, and they could look at the data of the patients they serve, the age of those patients they serve, and look at how many of them bring in caregivers, and where are the gaps in terms of the kinds of calls they get from caregivers, the situations in terms of food insecurity or transportation issues that are mentioned, those kinds of things. And so once we did this care mapping through the dollars we had with our grant, we partnered with the University of South Carolina's one of their public health components called CARE, did a care mapping, and then we trained everybody in the office about where these opportunities are for them to do advanced care planning. Now, Medicare started paying for ACP codes back in 2016. But physicians, 2 years later, only 1% of physicians were actually doing it. North Carolina's Blue Cross Blue Shield automatically turned their codes on in 2016. South Carolina, however, our South Carolina Blue Cross plan didn't turn them on until 2020. I must add that we were the squeaky wheel to our Blue Cross South Carolina compadres. Now, I spoke with Dr. Stinson, who's a part of their innovation area, who's also working with Carinova. And he said, Marcette, when we did turn the codes on, we got immediate uptake, but now it's sort of leveled off. And the reason it levels off is there has to be a process in the office to be able to accommodate the staff that's there, to be able to do these assessments and then translate that into how to bill for those things. So we also know of a family practitioner, Dr. John Robb, who recognized that he could be doing this, and 5% of his practice revenue now comes from advanced care planning, because he put in having a nurse to be able to assist with that, and they track what they're doing on those annual wellness visits. Now, the downside and what we need to advocate for is, if you want to create access to particular groups, those who are not dually eligible but are under-resourced, to pay a copay at other times to have things done could be a detriment to certain people and to certain groups. Your dually eligibles, they're going to be fine, right? Because Medicare's primary, Medicaid secondary. But you have a group of folks that are Medicare who don't qualify for Medicaid, but who are also kind of fall between the cracks in terms of what their resources might be. So once we assess the practice, assess that, we've been missing out on doing these codes, then we create a care mapping process. We educated the staff, and then they began to operationalize it. So where they realized that on their intake sheet, they didn't even have a question about advanced care planning. So that was a simple change that they could make. And then we provided materials that they could give to their patients. So we provided ACP guides that we produced with the funds that we received, and we were able to do that as well. Matter of fact, on yesterday, when I called the office to find out if they were working with the caregiver codes yet, my husband's now a patient of the practice as well. I see the nurse practitioner, he sees the physician, and the office manager said, "Oh, Marcette, thanks for calling. Did you give me a copy of that advanced care plan yet?" She put me on the spot, right? And so because now it's a part of their mindset to think about doing this. And I see them up probably a couple times a year, right? And so anyway, I said, thank you for holding my feet to the fire. I need to bring that copy in. So I think that is what's going to work for us, is to be able to, I love what you said, that there are a couple of places in the country who've partnered with the AAAs, and we have a couple of folks that represent the AAAs on the call today. They are absolutely integrated grassroots with seniors. They are an absolute perfect partner for this kind of work. And so when I see that they are working with health practitioners to bring in the staff that can do that training, that's absolutely what's going to help physicians and nurse practitioners, because the checklist of things that they've got to do is so great. They need to be able to collaborate with a great partner and be able and have sort of a great business model about it, that assessment of what their practice looks like, and then how can they then, once they identify the gaps, how can they then be able to integrate this, which is really going to help caregivers. For example, the navigator approached me on one visit. I happened to be in, and the navigator was there, and she came in. And of course, I'm not thinking that I'm a senior, right? I'm thinking, I'm still working full time, even though I've got gray hair and I'm now 60, 60 plus. And so anyway, nurses never think that they're in the category of other people. And so anyhow, she asked me, are you having any difficulty getting to the doctor's office? Do you have any needs in terms of your medications, right? And I said, oh, this is wonderful. So I started asking her questions about what she was doing, because I could use it to share with other people. And so I found out that they were plugged into pharmaceutical companies to help people whose their insurance doesn't cover everything that it's needed for the medication, and they then could tap into some of these consumer supports in order to provide support for the payment for those meds. And so I thought, wow, this is a great resource. Somebody who needs a ramp built, someone, so these are things that are really going to help caregivers if they can have that kind of support, because they are navigating these issues for their loved one. And it can be very daunting if you don't know where to go and who to ask. So kudos to Wellspring Family Med. They are absolutely on the front lines looking at how they can integrate these kinds of things. Karen, I'll pause. I hope that was beneficial for people. And I'd love for us to sort of come together and think about a great strategy that includes community-based organizations who can help us. Telehealth, I think, is a must in certain situations. So that's a piece that I absolutely feel we have to advocate for. However, in some of our rural communities, we know that access to the internet is a challenge. In South Carolina, the Palmetto Telehealth Association received some grant funds to actually be able to assist seniors on how to navigate the internet and to look at, so there's funding for those kinds of things, but we need to connect with those folks that have those resources. So I'll pause. I know it's 9:10, and there may be some questions that you have for me or some other things before we wrap up.
Yeah, no, thank you very much. Again, Marcette and Autumn, I have an entire page of notes, actually going into page 2 of notes, just from what you've talked about, because some of those best practices that you just described, I think we could use for doing something like this. I think it's critical to have someone who's trying to connect those dots. I am intrigued that at the grant you got, because I'm thinking we really need to start looking at bigger grants because to take something like this on could be a lot of work. But also, I think we've got a great group of people. And like you said, we put our heads together with our sister coalition in South Carolina, and we figure out how, I know it'd be different state to state, but I do think that we've got resources for people who have done things that maybe we haven't done, and we can learn from them. One thing I want to ask both of you, we talk about assessments, caregiver assessments. In the 25 years I did it, I never took a caregiver assessment. Nobody ever asked me. I had one person toward the end of my mom's life ask me how I was doing. And it was because it was really when she was at the point where the person that was seeing her, it was the first time this person had seen her. She was in a really bad place. She looked terrible. And then this was when she was in a skilled nursing facility. And I thought that I started crying when the person asked me how I was doing, because nobody in all the doctor's offices I had been in had ever said, this must be really hard for you. And I loved her doctors. My mom had great doctors, but they don't have the time and staff. So when we talk about assessments, that assumes that a doctor's office is doing an assessment. I didn't see anything in here, and maybe I missed it. Is there anything in the codes that say anything about having to do a caregiver assessment?
That's an interesting question. The easy answer to that is no, not for the caregiver, at least through the CTS codes. And the reason is because the caregiver training services have to be directly tied back to the patient's medical diagnosis. So the services that would be provided to the caregiver would be dependent upon the assessment from the patient. Now, obviously, that is, again, an area of opportunity for advocacy. I think that was something that the National Alliance put into their comment letter, that assessment should be prioritized. I will say that there's coverage for the SDOH, social determinants of health risk assessment, again, for patients that are included in the health-related social needs portfolio of filling opportunities. But yeah, there's not a particular caregiver assessment that's a component of these.
So I see Livonia. Yeah. So Livonia, are you with a AAA or another community-based organization?
Good morning. I actually work for the South Carolina Department of Aging, and our AAA is in Charleston. We cover Berkeley, Charleston, and Dorchester, and we have a family caregiver program. And that is the primary thing that we focus on, is caregiver burnout, giving that caregiver a break. And so that caregiver assessment has to be completed on everyone. And then based on that, we have connections to if they need support groups or something like that. And then we offer the caregiver respite break that the AAAs have in the state to be able to pay for someone to allow them a break.
Right. So, and thank you for talking about that, because that's where, that's where Autumn is talking about the National Family Caregiver Support Program, with which many AAAs are the ones that are facilitating those. And that goes back to what we talked about at the beginning, which is physicians' offices and community-based organizations, or going up the ladder to AAAs. They don't talk to each other very much. And I'm saying that from my experience. So if anyone else has experience with where that is working, I would love to hear about it. I think we need to hear where there has been success.
Well, one of the things that I had the privilege of doing last year in the South Carolina Department on Aging, we happened to meet each other in July at Salt Lake City for the huge Aging Network. The U.S. Aging Network had their huge conference. And I was so impressed with what the area offices on aging are doing across the country. They are well integrated. However, they are forgotten in their communities about the fact that they're working with seniors and working with caregivers. So I think that's another tie-in that we need to make. Each one of our states also has a respite coalition that's tied in, as Lavanya said, with the Department on Area Aging to provide the respite pieces. I sit on the advisory group for South Carolina because I represent the end of life care industry. So, they always want us to be at the table so we can talk about what some of these issues kind of look like. Just recently did an advanced care planning thing for one of their groups, a workshop for seniors. So they've got the audience. And they have those caregivers. And so that really is a key for us we're not going to be able to do it ourselves, but we definitely need to partner up with others that are doing this work. So I will also say that when the patient's assessment is being done, one of the things that's going to be asked is, do they have a caregiver? And that's a little bit of how that link is made for the caregiver. So when those assessments are done either by home health or by hospice, they're going to find out what kind of supports, are there. And inadvertently, indirectly, the fact that the patient has got food insecurity impacts the caregiver. So you're able to make that bridge with that. But in terms of the caregiver's mental state, how they are doing, in the hospice world, we're doing anticipatory grief assessments more on what was going on with that caregiver burnout and breakdown. And so those are pieces that are part of that process. But for doctors' offices, I can recall, when my mom first died and I was having issues feeling like something was going on with my stomach. And I went to see a GI doctor. I was 29 at the time, 30, and just taking on two of my younger sisters to care for. And much like you, Karen, when I went into his office, he said, Marcette, there's nothing wrong with you. You're just going through a lot of stress right now. And I broke down crying in his office, and he let me sit there for an hour. That does not happen all the time. But I felt like I was seen and I was heard, and that somebody was extending to me some empathy for this work of me taking on this daunting task of raising two preteens and still trying to work, et cetera, and going through grief myself and not being able to grieve. So, and there's also grief issues with caregivers too. The change in what the home situation is like in terms of what they have to do for this loved one that they do care about, but it's different. And so I think Alzheimer's Association is another great big group. AARP has a caregiving piece. So I think these larger groups that are advocacy groups, that if we could partner with them, get some additional monies, we could make some changes. So guys, our time is rapidly winding up. I'm gonna hush.
I see Keisha has her hand up, so I'd love to hear from you.
Hi, thank you. Autumn, first of all, thank you so much. This was so informative. And I just wanted to share, I'm taking on a new role. I'm a clinical social worker through Cara Nova. We're piloting work with serious illness in the palliative care clinics. And I'm charged with doing caregiver assessments, and they are going to use the Zaret assessment tool. And it was just interesting because, of course, I'm at MUSC downtown Charleston, and there's no build-in in our Epic to even like start that process. And so it's just amazing. Now that I've been in the role for 2 weeks, I have probably gotten 20 referrals from our providers. It is all surrounding caregiver burden, caregiver issues. And Maricette, like you were saying, the anticipatory grief, I will tell you, it's a lot about loss of partnership, intimacy issues, all of those things to address when someone has a serious illness. And so, Autumn, this just could not be at a better time for me. Thank you.
Yeah, no, I'm glad to hear that. And again, I'll just say that I know on a community, regional, state level, implementation is the real key here. So if folks are looking for help with implementation, I'm happy, feel free to reach out to me. I'm happy to refer you. Again, I am not that person. Maybe I will be after a few more years of working deeply in this area. But, to the extent that I can help refer you, make connections, or, even connect you with folks who are maybe doing this already, I'm happy to. No promises, but the other component that I think you raised here is, looking at the caregiver training services specifically within the physician fee schedule. It's really important to understand what they are and what they aren't. And the caregiver training services, again, are focused on training the caregiver to take care of a patient. The other caregiver support services, the Family Caregiver Support Program through the Older American Lifespan Respite Care, Veterans Directed Care for those who are eligible, and others. That's really where the meat of supporting the caregiver comes in. And to your point, that is as important as ensuring that the caregiver has the skills that they need to do transfers or handle incontinence or wound care, et cetera, if not more important, arguably. So I think it's important to realize, that there's still, as much as a step forward as this is, there's still a disconnect. And I think that addressing that disconnect is, again, where some additional advocacy moving forward could help in terms of bringing community-based organizations and community workers closer to the caregiver training services opportunities in the physician fee schedule.
Excellent point, Autumn. I want to ask Erin Kent. I see your hand up. Dr. Erin Kent is a longtime friend of our coalition and is on our caregiver and patient engagement work group, as well as the caregiving collaborative. So go ahead, Erin.
Thanks, Karen. Thank you for these incredible presentations. It feels like y'all are so ahead of the curve in thinking about how to implement these into practice. And I come from primarily an oncology space. I'm a cancer health services researcher, and I work very closely with our comprehensive cancer support program here at UNC's Lineberger Cancer Hospital. And if there's any, and I also am the Cancer Caregiving Special Interest Group Chair for the American Psychosocial Oncology Society. There's a lot of interest in caregiver training services, as well as navigation services as a way to truthfully, increase service and outreach to caregivers. But there's like, you talked about that implementation issue. We're looking for help connecting or communicating to the oncology community. So I'm wondering if you all have any suggestions or even would be willing to come speak to our to our folks over in oncology, because I think, yes, these codes are for Medicare and they're intended just for training, but cancer is very much a disease of aging. We have a lot of folks receiving cancer care through Medicare, and we do have psychiatrists in our cancer hospital who could potentially be offering these services. Now, the truth is, it's going to be the clinical, the nurse navigators, the social workers who are really actually interfacing with caregivers. But if we could somehow communicate to that audience, there's so much interest in psychosocial oncology. So if you have any like referrals or information, or we could connect later, I have a couple of webinar and conference opportunities to provide you further to help get the word out, because people are very hungry for this kind of support.
Absolutely. I know that Karen is going to link us all together. And thank you, Dr. Kent, because one of the things I thought about as you shared is that, when we think about tackling the elephant one bite at a time, it could be doing a pilot with one particular disease specialty group. So since you've stepped up to talk about oncology, that could be a potential group that we could begin with. And then bring in partners that support what that work is. So let's definitely get together and talk about what that could look like. Because if you create a great pilot and it works well, and usually if you're going to do a pilot of any kind of significance, you can get funding for it. And you can then do it more broadly. So let's think about how that would work. We are at time, guys. I know, man, we have been having so much fun. And I absolutely, on behalf of the South Carolina Coalition, our CSI group, we want to thank you, Autumn, for just a wonderful, informative presentation. Now we've got more questions, and we also now have passion to really advocate for where those gaps are because of what you shared with us. And Karen, your insights invaluable today. So thank you so much for that. We will get the recording and the slides out to everyone. It will live on our website once we get through this week. So our website will send the link out to all of our registered participants this week. And you guys will know when the slides hit and when the recording is out there on our My Life, My Choices website. Many thanks to our education committee for putting this on. Thanks to Heather for connecting us with our North Carolina partners and family, and so that we could have this amazing presentation today. On tomorrow, we will resume the last day of our summit, virtual summit, and we are going to be talking about advanced care planning and the intersection between clinicians and faith community conversations. What does that look like, and how do we honor what both entities need through that intersection? So we'll be having that talk on tomorrow morning at 8 o'clock. We look forward to seeing you all again. And the evaluation is going to be coming to you as well. And so you will receive that evaluation. We have one for each day. And so you'll be getting that as well. Jessica will be sending that out to you. We decided we would not send you emails every day because we know everybody gets inundated with a lot, but the link is there in the chat. If you want to go ahead and put your evaluations in for today, you can go ahead and do that as well. We welcome your feedback. So once again, on behalf of CSI, many thanks to all of you who are on. A couple people had to jump off because they've got those 9:30 appointments, right? And so we look forward to seeing all of you again in the morning. There's still time for people to register and participate. It's free. And so we want as many people to jump on as well on tomorrow. Thanks again, everyone. Have a great day.